Welcome everyone to the Benefits Compliance 2024 Mid-Year Check-in. Thank you all for joining us. Kelly Eckman will be answering the questions you send through the Q&A today. We will try our best to answer all of your questions, but if for whatever reason we are unable to get to your question today, please follow up with your advisor for further assistance. Today's presentation is being recorded. We will be sharing the recording in the follow-up email and on the NFP website. If there are any portions of this call that you missed, by Monday, you'll receive an email with a link to the full recording. The PowerPoint slides used during this presentation will be shared in the same email. At this time, I'd like to hand over the call to Sharon Cohen, Vice President and Counsel of Benefits Compliance at NFP, and Kelly Eckman, Vice President of Benefits Compliance at NFP. Kelly, the floor is yours.
All right, thanks, Amber, and welcome everyone to Get Ready for Summer, Benefits Compliance 2024 Mid-Year Check-in. Okay, so this is something that we've done the past couple of years, sort of just taking a look at, what has happened so far this year, and then kind of finishing with some things that employers need to kind of still have on your radar, maybe some deadlines that are coming up, or just some items that we think we're going to see some movement on as the year progresses. So we'll cover a lot of topics in a little bit of detail and provide some resources as we can along the way. Before we get too far in, we always like to remind people that, what we're talking about today, this is just general guidance purposes. Okay, so this is not tax advice. This is not legal advice. If you have those questions, please take those directly to your legal counsel or your tax counsel. The information that we are discussing is current as of today. So here are our smiling faces. So I know some of you heard Sharon in our most recent Get Wise Wednesday last month, and then this is me. So I've done a few of these for our team over the past few years. So we're going to be taking you through these 2024 updates and kind of, again, the look back as to where we are this year. So again, here's our agenda. I know it looks pretty packed. We're going to move through some of these just kind of in small increments, but we do have a lot that we want to cover. So we're really going to look at, new guidance. So what has come out so far in 2024 that employers need to be aware of? And then we'll look at our no update updates. That's a very legal and professional term, but just some of those items that, we have employers asking us about. We don't really have any big updates, but it's helpful to sort of look at those and just kind of think about, why should this still be on your radar as we go on. We'll have a legislative update. So look at, what's going on Capitol Hill and maybe some things to think about as we head into election season. And then we'll wrap it up with business as usual. So some of those upcoming compliance deadlines that should be on your radar, and then look at some of the annual amounts that have been updated for 2025 so far. Okay, so we're going to, again, start with our new guidance. So, we're 6 months into the year so far. We've actually had several items that have come up where we've received final rules. So often we're working on proposed rules for some of these topics and kind of, helping advise employers as we can. And then when we get the final guidance, it's helpful to review it. And most of these we've actually discussed in our Compliance Corner articles that come out every 2 weeks. But I think some of these are important to really kind of address and call out in this format just to make sure that they are on your radar. So the first one we're going to look at here is Section 1557 of the ACA. So these are the ACA's non-discrimination regulations. Okay, and so, kind of the big part of Section 1557 is that it's prohibiting covered entities, which we'll talk about these in a minute, from discriminating on the basis of a protected status. And so when we're looking at this legislation, that protected status is going to fall under race, color, national origin, sex, age, or disability. Okay, and so I said, well, covered entities, those are the ones that cannot discriminate based on these factors. So what is a covered entity? Okay, so this definition is a little more narrow than what employers may think about. So covered entities for these purposes, they are participating in programs that are administered by HHS, so Health and Human Services. Their health programs or activities that are receiving federal funding from HHS agencies. So agencies like Medicaid. So that federal funding is sort of a big piece here. And then covered entities for these purposes are also the public marketplace. So those individual policies that are being sold out on the exchange or the public marketplace. So these rules are kind of interesting. So we have here the, administrations have played interpretation ping pong, which I really think is a good description here, because these rules under 1557, so they've been in place since 2016. But then in 2020, with the next administration, the scope was limited quite a bit. So they amended the rule and they limited the scope of applicability under Section 1557. Then 4 years later, here we are. We got a final rule earlier this year in 2024, which essentially reinstates the original 2016 scope of these rules. So we've kind of gone back and forth with, how broadly or how narrow these rules have been discussed. So the big thing here, where are we now with 2024? So again, covered entities cannot discriminate on the basis of sexual orientation or gender identity. So this 2024 update gave us explicit protections on the basis of gender identity. So that's where, again, it kind of broadened this rule. Sex discrimination, so that can include discrimination based on stereotypes, characteristics, and pregnancy. One thing that we do have now is an annual non-discrimination notice. So those covered entities mentioned above, they must begin giving an annual notice to covered individuals. So this will actually begin in November of this year. So a new requirement, again, on those covered entities. And then this final rule also let us know that this applies to telehealth as well. So, what do employers need to know? You're sitting here thinking, well, I don't receive federal funding. I'm not a program administered by HHS. Why does this matter to me? Well, it matters because we really have that direct impact on the carriers and the TPAs. And if they're directly impacted potentially, then there's an indirect on the employer plan, the plan sponsors. Plan sponsors, if they have discriminatory plan designs that are going to be, have one of these discrimination factors that we mentioned above, they may have to remove those factors so that the plan is no longer discriminatory. So employers, plan sponsors always want to make sure that you're checking with the insurance carrier, your TPA, your PBM, in case there are changes that need to be made to your plan, because obviously you don't want to have a discriminatory plan and then deal with kind of the fallout of that. And so why is this important? Well, discrimination on the basis of sex has been one of the most litigated provisions of these Section 1557 rules. We've actually seen some recent court cases. I know there's one in the Fourth Circuit recently regarding gender affirming care. So we think that Section 1557 rules are really going to be in the spotlight lately. So making sure that your plan does not have any of these discriminatory designs is important. And because we're likely going to keep seeing this is probably something that will reach the Supreme Court sometime in the future. So it's definitely important that employers and plan sponsors have it on your radar. I have a link here at the bottom to an NFP resource, so an article that we wrote on the final rule earlier, in case you do want to do a deeper dive into that rule. Earlier this year, we also got some updates on fixed indemnity rules. So this was back in April. And this final rule really just modified some requirements for fixed indemnity insurance, although it also sort of left us with some open holes as well. But one thing here, they're trying to make sure that, for hospital insurance or fixed indemnity products, the original design of these was just to make sure that they were income replacement vehicles. Okay, so they were just going to kind of fill a small gap. However, these products in some markets have actually expanded and become much more comprehensive. So the concern from the departments is that someone may get confused as to whether their fixed indemnity coverage was really more of a major medical plan or not. The big thing with fixed indemnity plans is they want to maintain their accepted benefit status. And why is that important? Well, that's important so they can avoid certain ACA mandates under that benefit. So a fixed indemnity plan doesn't have to provide preventive care. It doesn't have to comply with annual or lifetime dollar limit prohibitions. And so how does a plan continue to keep that accepted benefit status? Well, the big thing here is that those plans have to pay benefits on a per day basis or some other stated time period. So it's not going to be tied to the actual expenses or the actual services being incurred. If a plan like that pays per medical item or pays per service, it would not be considered an accepted benefit. Now, it's important to understand here that these requirements have been in place for the group market for years. Okay, so most fixed indemnity plans that are offered on the group side should already be complying with this, but individual policies didn't have to comply with this. So that was a clarification that this final rule helps make. And then there's also a consumer protection notice, so another annual notice requirement. Basically, carriers that are writing these types of policies have to have a notice that highlights the differences between what is a fixed indemnity plan and what is a comprehensive medical plan. That requirement will go into effect for plan years beginning on or after January 1st of 2025. Now, I mentioned at the beginning, some of these rules are still sort of open-ended. So the agencies are really still reviewing some other aspects of fixed indemnity plans. Part of that has to do with tax treatment. So how would the payments that someone receives from those fixed indemnity plans, how are they taxed or not taxed on the value of that? So we think that we'll see some updates on this topic in the future, but for now, this final rule in April really just gave us that annual notice requirement. So what do employers need to do? Well, again, make sure that your plan meets accepted benefit status. Again, it should, group plans, but always good to confirm. There will be a notice requirement that those carriers will have to start doing next year. And then just sort of keep an eye out for those potential tax issues and changes that we may see as this goes on. So we anticipate getting some updates on this as well. And obviously we will report those. Again, here's a link on the slides that you'll be getting later that goes to our NFP update on these rules. So at the same time that we got the fixed indemnity rules, we also got something on short-term limited duration insurance. Okay, so this is something, again, the final rule came out in March of this year. And really, it's just trying to define limits on these short-term limited duration plans. Okay, and so what are these? So these products came about, in theory, trying to help fill some gaps. Maybe if somebody was in between jobs and, COBRA is too expensive, but they still want to have some health coverage. That was kind of, what these were designed for. The big thing to note here is these are individual plans. They typically are very limited in scope and what they offer. So they have higher out-of-pocket costs. They're not going to cover, as many services as a major medical plan, but this also helps them avoid certain ACA mandates. So they can avoid pre-existing condition exclusions, those annual and lifetime dollar limits on essential health benefits, those kind of things. And in fact, the ACA says that these short-term limited duration insurance plans are not considered health insurance. So these rules said, hey, these are supposed to be short-term. However, as the years have gone on, these policies have actually allowed people to stay on them for up to 36 months. Okay, so this rule is basically saying 36 months is not short-term. We want to change these rules and we're going to limit this to 4 months. So you get a 3-month initial term and then up to 1 month on a renewal. So the rule is saying policies that are sold before September 1st of this year can still have up to 36 months, but if it's on or after September 1st, it is limited to 4 months. Again, another notice requirement. Those plans will not have to give some information about, the coverage limitations and why this is not comprehensive health coverage. So what do you as the employer need to know here? So again, these are really individual plans. So it's not something that you as the employer are sponsoring in the group health world, but it's still important to understand because you may have employees, so new hires, who had one of these plans while they were between jobs, or they're between jobs and then they're waiting for the waiting period to join your plan. They get notice requirements. They would be getting that from their vendor. The last bullet here is kind of interesting. So there's kind of a gray area here as to whether or not if you have an employee who's on one of these short-term limited duration insurance policies, let's say they have that 4-month window or the 36 months that's ending. Once that coverage ends, is that a give rise to a mid-year election change event? So would that trigger that? And so it's kind of a gray area because, again, the ACA says that this is not health insurance, and it's definitely not group health insurance. So employers really have to be mindful and kind of dig into, if they had a situation where someone had one of these policies ending, is that going to give rise to an enrollment right for them mid-year? And again, we cover this information as well during in an article on Compliance Corner. So we've got our link down here as well. And then the last one I'm going to talk about here are gag clause updates. Not necessarily new, but we did get a little clarification, so I think it's helpful to discuss. So gag clause attestations. So the CAA, the gift that keeps on giving, one of the provisions there is that it prohibits plans and issuers from entering into agreements with healthcare providers, TPAs, other service providers that directly or indirectly restricts the plan or issuer from making certain data available to other parties. So that's your gag clause, not being able to share that data or make that data available to others. So there's an annual attestation requirement. Hopefully everybody listening took care of this, or your carrier took care of this last year. So it's due every by December 31st of each year. But we got a little guidance earlier this year, so I think it's important to talk about for just a moment. So the attestation can actually be made at any time during the year. It just has to be done before December 31st. And so that means you don't have to wait until December. We know everybody's busy, especially if you're a calendar year plan. You could choose in July of each year to file this attestation if you want. When you file that attestation, it covers the period from the date in which you last filed an attestation through the date that you are filing it. So it's definitely possible to do it earlier in the year if that is, kind of eases the administrative burden for a plan. Now, as a reminder, who has to file this? So fully insured plans, the carrier is going to handle it. But if you're a self-insured plan, technically it's up to you. Now, self-insured plans, you can contract with your TPA to make that attestation for you, but the obligation ultimately still rests with you as the self-insured plan sponsor. So even if you are working with your TPA, you do still need to confirm that they actually do make that submission and then it has been made on your behalf. And again, a link down here to the updated information on gag clause. Again, it's really just letting people know that it may be a little more flexible on the timing front if you need it. And now Sharon's going to go ahead and walk us through the next piece of new guidance that we've gotten thus far this year.
Yes, I am. Thank you, Kelly. So I am going to talk about the reproductive healthcare privacy rules. HHS's Office of Civil Rights just finalized rules to support reproductive healthcare privacy. So these new rules amend previous final rules, and the purpose of this amendment is to restrict the circumstances in which covered entities and business associates, which are referred to in the regulation as HIPAA-regulated entities, but to which they can disclose an individual's reproductive health information. So I'm sure, as everybody knows, under the HIPAA privacy rules, these HIPAA-regulated entities are prohibited from using or disclosing PHI, which is protected health information, without obtaining an authorization from an individual, unless there's a specific exception that would apply. And PHI can be used for purposes of treatment, payment, or a healthcare operation. Those are the exceptions. But the exceptions also include uses and disclosures that might be needed to be made for a variety of public policy purposes. And among those public policy purposes is law enforcement activities. And the final rule expressly permits covered entities and BAAs, which are these HIPAA-regulated entities, to disclose PHI to law enforcement officials. For example, in circumstances that are response to a subpoena or a warrant that's issued as part of a law enforcement investigation. So HHS had some concerns that in a post-Dobbs environment, where states are taking action to restrict abortion access, this law enforcement exception could threaten to undermine the primary goal of the HIPAA privacy rule, which is to protect the individual's information and to foster a trusting relationship between individuals and their healthcare providers. The preamble of these regulations, HHS says that they heard from patients and providers who were confused about their legal risks or who had deferred care because of this worry about a legal risk. So this rule change basically prohibits physicians, insurers, and other healthcare organizations from disclosing health information to state officials for purposes of conducting an investigation, filing a lawsuit, or prosecuting a patient or provider. It covers women who cross state lines to legally terminate a pregnancy and those who qualify for an exception to their state's abortion ban in cases of rape or incest or a medical emergency. The final rule imposes also a new requirement that in certain circumstances, regulated entities must first obtain an attestation that the requested use or disclosure is not for a prohibited purpose. And this would be the case where PHI is related to health oversight activities, judicial or administrative proceedings, or in the case of law enforcement. And where the PHI is potentially related to reproductive health care. So in that sort of situation, the requesting entity must provide an attestation to the plan that, or the covered entity rather, that the request doesn't violate the privacy rule. This rule has a direct impact, of course, on self-funded plans, self-insured plans, but there's also an indirect impact on insured plan. So it's really important for all employers to confirm the compliance with this rule with the insurer, the TPA, or whomever handles the privacy practices for the group health plan. Additionally, the final rule requires a modification to be made to adjust for this, this new requirement in the notice of privacy practices. And OCR is going to issue a model notice that contains updated language, which is very nice, for all of us by February 16th of 2026. So they have a couple years to do that. It is also important for any entity that maintains privacy practices and procedures and training to update all of those procedures and train their individuals so that they are informed about this rule and can, compliance can be in accordance with it. And you will see that we again leave a source here from NFP to look for more information about this at the bottom of the slide. Kelly, let's move on to work-life referral services. So in April, the IRS issued an FAQ, and it addresses the tax treatment of employer-provided work-life referral service. And you might be asking yourself, what the heck is a work-life referral service? Because I would love that for myself, just based on the title of it. The IRS describes this as a program that is informational referral and consultation that assist employees with identifying, contacting, and negotiating with life management resources for solutions to a personal work, or family challenge. That is a mouthful. But basically, these are programs that help employees, maybe find appropriate childcare for them. Maybe they have a special needs education program and they have no idea where to look. What they might be looking at, requiring some home services for a situation where their home needs some adaptation for special needs, navigating the medical system. It's basically a social worker in a bottle, I guess. And so there are employers that provide these programs to their employees. These are called like lifestyle programs. They're basically employee perks. When someone is in need of this kind of thing, this is a service that will provide that, and it's a great comfort to employees to have it. Sometimes we see these programs and they're incorporated in an EAP. And the EAP might provide resources beyond just referrals. That is not the situation that the IRS is referring to here. Sometimes you might find this sort of program embedded into what you might think of as unusual benefit, like a dental or vision plan. I have seen that last year in my work as an account manager. They might provide, as an aside to the main core of the benefit, the sort of other service that has these types of referrals. The IRS is really just talking here about these specific referral services. And the question is, if the employer pays for this benefit, can it be excluded from the employee's income? So we know in an employment relationship, anything my employer gives me, like a perk like this, would otherwise be included in my income unless there's a special provision in the Internal Revenue Code that would exclude it. So we have a provision, for example, for healthcare. That's an easy one. We have a specific provision in the Internal Revenue Code that allows that to be excluded from an employee's gross income. But there is also a provision in the Internal Revenue Code for something that's considered a de minimis fringe benefit. And if it is a de minimis fringe benefit, then it can be excluded from taxation from the employee's gross income. So the thing is, to be a de minimis fringe benefit, it has to be something that an employer would give to an employee that is so small and so infrequently used that it makes accounting for it to be unreasonable or administratively impractical. And that is where the IRS falls on the taxation of this kind of benefit. So it has to be this sort of referral service, not something where you are going to really receive any sort of resource or benefit like counseling services. And I'll also note that the IRS was really focused on programs that charge a per employee monthly fee. So if you had a program that differs from that, where it's a per service fee, it may not work for this situation. And it would be important to look to counsel if you have this sort of program that goes beyond referrals, that goes beyond an employee per employee monthly fee, to look beyond that and maybe look at seeking counsel about whether you can exclude it from gross income. This is a FAQ. It doesn't have the force of a regulation. And so any kind of program that might differ or is more comprehensive could be subject to additional scrutiny. And so it would be important to seek counsel if you need that for that kind of program. The next one is these essential health benefits. So when HHS finalized the 2025 benefit and payment parameters this spring, it also released an FAQ clarifying its position on certain prescription drugs for plans that are offered in the large and self-insured market. Basically, HHS has this position that prescription drugs that plans cover that are in excess of those covered by a state's essential health benefit benchmark plan are considered essential health benefits. And then if they are essential health benefits, they are subject to an annual limitation on cost sharing and a prohibition on annual and lifetime dollar limits, unless the coverage of the drug is subject to a state mandate. So if the drug is not considered an essential health benefit, then the annual limitation on cost sharing, et cetera, would not apply. So for certain drugs, a group health plan might implement programs to control drug spend. Sometimes these are referred to as copay or cost-sharing maximizers. And they might design a program where the patient is allowed to make full use of a drug manufacturer's copay assistance, or they might want to cover the drug, but they need to have a little bit of a higher cost sharing to be able to afford the drug. And if the drug is considered an essential health benefit, then it would be subject to the cost sharing provision, and this would not be allowed. So for now, this provision applies only to the individual and small group market. The reg at the moment does not discuss what this means to large group or self-insured market, but this FAQ gives us an indication that the agencies, the departments intend to propose rulemaking that this policy, this provision, would require plans that are in the large group and self-insured market to treat prescription drugs similarly to the way that it's treated for the small group market. And so we're not there yet, but a change like this would definitely have an impact for self-insured plans and employer group health plans. It will increase costs. And so now I'm going to turn it over to Kelly to give us an update on the updates. Or the no update, sorry.
Thanks, Sharon. Yeah, definitely the official no update updates here. So we do have a couple topics that I think have gotten, some airtime this year that employers are definitely interested in and would love updates on, but we don't have them. But I think it's still important to kind of revisit those and see where we are. So the first one on here, so the Johnson & Johnson class action complaint. So I think most people are aware of this from earlier this year. So it's the class action lawsuit that was filed that basically alleges that Johnson & Johnson, in their role as plan sponsor, failed to meet its ERISA fiduciary obligations because of the PBM that they selected. So the complaint argues that it did not pick a PBM with favorable pricing terms. And so some of the specifics in there point to the fact that, it alleges that some generic prescriptions under the plan were up to 250 times higher than someone would pay for that drug if they didn't have insurance. There was a significant markup on other specialty drugs. But interestingly, as a whole, the plan actually did not have large markups across the board. It's just some of these specific ones that the complaint alleges had very large markups. So I think that's why, kind of became a case of interest for a lot of people. And it is interesting to note that, ERISA doesn't say that plan sponsors have to use the lowest cost vendor. Okay, so that's not part of it. It really just means that, there are other factors that employers would consider when they're selecting a PBM, like in this case. The big thing is to make sure that, when employers are going through that process, that they're documenting their decision-making process. So not necessarily the outcomes, so the dollar or the cost that was chosen, but, what process did they go through as they were selecting that vendor? Why did they make the choices that they made? So like we said, any updates? Well, no, not really. We don't have updates at this time. We're really going to see the litigation kind of play out in the courts and wait and see what kind of ruling we get. You know, we anticipate that Johnson & Johnson would file a motion to dismiss. So it depends on, you know, how that goes. If the motion is denied, we'll likely see, you know, copycat cases. So if the plaintiffs are successful here, you're likely going to see plaintiff attorneys looking to file more suits in similar cases like this where they can. So I definitely think it's something that we're going to continue to see. We just don't have an update just yet. But it is important for employers and plan sponsors to understand that, you know, we are seeing more scrutiny on health plans. We have all these new transparency laws that are really bringing, you know, cost to the forefront. And so it's important to understand that, you know, we are going to be seeing this quite a bit. And so, you know, what do employers need to do? Well, employers obviously need to make sure that you are engaging in prudent decision-making processes. So when you're picking your service providers, your vendors, your TPA, make sure that you're documenting the processes. You want to document the fact that you are reviewing the contracts and you are, you know, why are you choosing those vendors? Maybe it's not just from a cost perspective, but do they have a better network or whatever those things are, just making sure that you are documenting it, you know, if you need to show that. So it's really just kind of reminding employers that they do have this duty of prudence to make sure that they are, you know, making the best decisions for the plan. We do have an NFP resource on this where we discuss this case quite a bit and just kind of, again, what employers need to think about. But this was sort of our litigation non-update at the moment. Obviously, if we get updates on the case, we will certainly be reporting that in our Compliance Corner emails as well. So our next one here, so mental health parity. So sometimes called Mental Health Parity and Addiction Equity Act. You'll sometimes hear it called MAPIA, right? So this is one that, again, is getting a lot of attention. We've kind of been trickling some things in here, but it's important to understand, you know, what are these MAPIA laws and what do employers need to be thinking about as we're waiting for an update here. So, you know, with these mental health parity rules, so group health plans, they're required to have the same non-quantitative treatment limits, those NQTLs, for mental health and substance use disorder benefits as you get for medical health. Okay, so making sure that those benefits are provided in parity with, you know, medical or surgical benefits that might be under the plan. So those mental health or substance use disorder benefits shouldn't have financial requirements that are more severe, or they shouldn't have, you know, pre-authorization requirements that other benefits do not have. The thing that we're focusing on here is the fact that insurers and TPAs must have written comparisons available for the plans, which are called comparative analysis. So this is something that helps a plan justify the inclusion of any potential NQTLs. So it's not saying that there can't be an NQTL, but plans need to be able to justify why it is allowed to be in the plan. And so, you know, this comparative analysis is something that, you know, a plan may have to provide to federal agencies or to plan participants. And so, you know, self-insured plans, again, we've mentioned before, you know, a TPA may say that they can help produce the comparative analysis, but ultimately the self-insured plan still retains responsibility for that. So some NQTLs that may be kind of red flags. So those things that if these are in your plan, you really may want to take a deeper dive and look into kind of the justification for why those are included. So again, I mentioned different pre-authorization or certification requirements, differences in cost sharing. One of the biggest ones we've been seeing is if a plan has exclusions for ABA therapy or other autism spectrum disorder treatments. So that's really a big one that we're seeing focus on. So if your plan excludes ABA therapy or other autism spectrum disorder treatments, you really want to look into that and potentially consider, you know, removing those, because those are red flags that the departments have been looking at. So what do employers need to know? Again, as we're back to that idea of that comparative analysis. So when there was a request for comments that was made, like 9,500 comments were received. So there's kind of a lot to be going through. We're still waiting for a report to Congress that will hopefully give us more insight, because while we've seen information about what is a deficient comparative analysis, we don't have examples of what is a good comparative analysis, what is sufficient that the departments want to see. So we're hoping to get that guidance soon, likely before the elections, hopefully sooner rather than later. But for now, go ahead and make sure that you are reviewing your plan for any of those potential red flag NQTLs. Make sure you're looking at your administrative service agreements. Does it address the fact that a comparative analysis is needed? If so, who's going to be doing it? Who's going to handle disclosures to participants or those responses to the DOL or CMS? So just reviewing those agreements to make sure that it's being handled while we wait for some additional information on comparative analysis requirements. And then Medicaid unwinding. So again, this isn't not necessarily not an update, but it's been going on for a while. So when we had the pandemic, Congress required that Medicaid programs in states had to keep people continuously enrolled through the end of the public health emergency. So that ended back in April of 2023. And so states have had varying levels of disenrollment processes for Medicaid participants who are no longer eligible. Most states said it'd be around a 12-month process, but each state does it a little differently. So it's just important to understand for employers, because, as these states are unwinding their programs, you may be receiving more requests from individuals who are losing their Medicaid coverage. Sometimes you'll see a lag between when the coverage was lost and when they actually got notified. So maybe their coverage was lost in December, but they didn't get the notice from the state office until April. So that can definitely complicate, how you handle those mid-year election change events. So definitely make sure that you are, looking out for those if you have employees who are letting you know that they lost coverage. Obviously, in those cases, you're going to want to look into it and see, when was the employee actually notified of that loss of coverage, especially if that loss was a few months prior. So again, no big update there, but just making sure that you are aware as states continue to unwind these programs, you may have more requests coming in from employees. And now Sharon's going to lead us through a legislative update.
Thank you. So I live in the Washington, D.C. area, and for whatever reason, I volunteered to give you a legislative update and to talk a little bit about the presidential election and the platforms as they relate to healthcare. As you might imagine, on Capitol Hill these days, we are mostly finding and seeing gridlock. And this is often true in an election year, but it's pretty contentious right now. So in an environment of gridlock like this, and particularly again in an election year, there is a lot more emphasis, because nothing is going to happen on the Hill. There's a lot more emphasis on regulatory activity. And I think, Kelly alluded to that in the beginning of our discussion today. We have really seen a lot of finalization of regulations and a lot of regulatory activity. And generally, the incumbent president wants to get out as much as he can, or she, but it's been he's, as much as they can before the end of the term, sort of not knowing what the future holds. We've seen this, every election season, there's this huge push for regulations that happens in, August and September. So they're trying to get it out fairly early, because if we have a new administration after January 1st, there's a provision that allows them to pull back regs that have been issued. And we have seen that occur in administrations again and again. So they want to try to push out as much as they can so that it's out there. They've got their stamp on things. And this is part of the reason why we think that the mental health parity regs will come prior to the election, but we just don't have a good grip on when that's going to happen. Even with the gridlock, we Congress has spent some time focusing on employee benefit issues. There's probably unlikely any chance that we're going to see any action before the election, but never say never. And so recently the House Education and Workforce Committee requested some information on ERISA preemption, and they held a hearing in April. And there, a bunch of employer groups came to testify and express their concerns about the erosion of ERISA and the importance of ERISA on employer-provided healthcare. There have been several bills floating around Congress that are focused on transparency, lowering healthcare costs, increasing access, and those bills, I looked at one in particular. It's called the Lower Costs, More Transparency Act, and it promotes honest hospital billing practices and would require PBMs to provide detailed annual reports to plan sponsors on prescription spending. And there is a fair amount of bipartisan support for these kinds of bills. And so it's possible that something gets put into the year-end budget package. And another law that we are really looking for to be part of that year-end budget package is the telehealth provision. And this provision allows high-deductible health plans to cover telehealth services before the deductible is met without affecting HSA eligibility. And it is set to sunset at the end of this year, unless Congress does something. And my understanding is that there is a bill that is ready to go to make this law permanent. It has bipartisan support, but it has not yet made it through, and it is it's anticipated that it could be part of the year-end budget package, but only time will tell. Otherwise, that law will sunset. And I just want to mention briefly that the House Republican Study Committee put forth a budget proposal, and there were a few items in there that would impact employers. They want to expand HRAs. We're ahead one slide, Kelly. And make health coverage more affordable and put back the limited duration plans that the Biden administration, Kelly just spoke about, that they limit. But they are also calling in there for a provision for capping the exclusion to the employer-provided health coverage. The language is very vague. I could not tell which taxpayer they were talking about, whether they were talking about the employer. When I read it, I really believe they're talking about the employee, capping the exclusion for the employee. But it is some version of that. And so, the question is there an appetite for that on the Hill? Maybe not this year, maybe in the coming years. Is this a version of the Cadillac tax 2.0? So let's move on to the candidates. And with no small trepidation, I want to just briefly touch on their platforms. I did go down the rabbit hole a little bit on this, but I can tell you it's important as part of the employer community providing healthcare and welfare benefits that we keep an eye on it. And what I found actually might be a little surprising is that there's more commonality than you would think. Both candidates have issues at the forefront. And in some ways, they really look at them differently, but in a lot of ways, they really look at them the same. So I've listed them here. I'm not going to reread that for you. In terms of lowering prescription drug costs, U.S. consumers generally pay 3 to 4 times higher for the same drugs as consumers in other industrialized countries, just like the UK or Canada or Japan. And both candidates want to address this issue in different ways, but they both want to address that. There's also a lot of emphasis on Medicare and changes to Medicare. And I went down the wormhole on that. So Medicare basically drives the big tour bus. I'm talking like the Taylor Swift tour bus of tour buses. And CMS, on behalf of Medicare, has huge spending power. And studies show that cost savings and Medicare gains through this power of negotiation for things like provider rates and drug care costs, they actually spill over into the private sector. They affect employers. And so it has an effect on private insurance companies and how they set up their drug reimbursements rates. So if you are like me and your brain turns off a little bit when the discussion turns to Medicare, turn it back on, because savings there will spill over to what you as an employer are saving, are spending in terms of your employees' health coverage. So quickly onto Biden's platform, he makes as his goal strengthen and protect Medicare, Medicaid, and the ACA, improve access to coverage, decrease costs. The platform proposes to lower Medicare eligibility from 65 to 60, to expand the ACA insurance marketplaces, to make ACA premium tax credits more generous, expand long-term elder care. He proposes to make many of the price concessions that have been gained from CMS negotiations to apply them to the private sector, expand private a section of Medicare that requires drug companies to pay a rebate on drugs when the cost of that drug has risen faster than inflation. And he would like to impose that in the private sector as well. And the platform also discusses allowing the importation of prescription drugs so that US purchasers pay the same as those in other countries. Now, if we go to President Trump, his platform talks about strengthening and protecting Medicare and Social Security, lowering healthcare costs. Some of the things that he implemented in his presidency, the Biden administration has pushed forward, like an effort to contain prescription drug costs, transparency, surprise billing, the gag clauses. The Trump platform also discusses this notion of favored nation status to prevent pharmaceutical companies from charging significantly higher prices to US consumers. And he also advocates for US companies to produce medication in the US and not to purchase drugs from outside of the US. He would like to put back many of the things that the Biden administration has scaled back, like the Section 1557 non-discrimination provisions and short-term limited duration insurance that Kelly previously mentioned. And now that's enough about the campaign trail. I'm going to turn it back to Kelly to remind us about some business as usual issues and walk us through some upcoming deadlines.
All right, thanks, Sharon. Yeah, it's going to be interesting to see as the election goes. I'm sure we will be covering, once that's over, we'll kind of be revisiting those topics to see how the election may be, updating and impacting employer plans as time goes on. But yeah, we're going to round this out with business as usual. So some of the things that, again, just kind of have on your radar as we move through the year. So this slide is just a little snapshot of upcoming compliance deadlines, although one very recent. So June 1st was the RxDC reporting deadline for 2023 year. So hopefully you or your insurer did this. So I did keep that on there just as a heads up, but otherwise, in July, depending on your plan, if you're a calendar year plan, you have a Form 5500 deadline. If you're a self-insured plan, you have a PCOR filing and fee deadline. In September, we have those MLR, so medical loss rebate ratios. So sometimes plans will get those rebates from the insurer and they have to distribute those or use those for other permissible uses. Not every plan will receive one. I think over the years it's been fewer and fewer, but if you do receive one, you do have to act by September 30th. Summary annual report. So again, if you file your 5500 by July 31st, you then need to distribute the SAR to covered employees by September 30th. I do want to mention this next one. So Part D disclosures, October, it seems so far away, yet it's pretty close, I think. So again, this is when you have to give that Part D notice of creditable coverage to individuals. So ahead of the Medicare open enrollment. The one thing we do want to mention here is just the Medicare Part D formulary to determine whether or not a plan has credible or non-credible coverage. That is changing for 2025. So it may mean that plans that were previously creditable may be non-creditable. It doesn't change the fact that you have to give this notice to employees in October. But I think it's just important to mention that, again, if a plan is changing from creditable to non-creditable, you always want to kind of take that extra step to make sure there is clear communication to employees so that they do understand if there's someone that needs to have creditable drug coverage, what their options are. So again, the requirement's not changing, but just maybe its importance could change a little bit depending on your plan. And then October 15th, if you were someone who, again, had that 5,500 deadline and you filed an extension, that would be due October 15th with the SAR due December 15th. Here's just a little snapshot of a compliance calendar. So we have one of these for every plan year month start date. So whether you're a 1-1 plan or a 4-1 plan, this is just a nice little snapshot that you can request from your consultant that just kind of gives you an overview of compliance deadlines throughout the year. So if you just want a quick little look to see what you might need to think about throughout the year, this is a great resource. So definitely request that from your consultant if you do not have this currently. And then to round it out, so we mentioned that, we have received some 2025 annual limit updates and penalty updates. Unfortunately, it's not the health FSA limits. Those are the ones everyone wants. And of course, we know we usually don't get those till November. Instead, we get HSA and EBHRA limits. So again, HSAs, no surprise, they'll go up incrementally for 2025, single and family coverage. And then the minimum deductible for a plan to be considered a qualified high deductible plan, which then means that you can, offer that as an HSA compatible plan. Again, very incremental change in minimum deductible and out-of-pocket maximum limits. So no surprise there on these limits. They typically go up just a little bit each year. Again, we have a nice publication on this. So if you want just kind of a one-stop shop for these annual limits, request it from your consultant again. And then to round it out, ACA employer mandate penalties. So what's interesting here is the penalties are actually decreasing in 2025. A very small decrease, but a decrease nonetheless. So penalty A, so again, that's assessed if you don't offer coverage to to substantially all of your full-time employees. And then penalty B is the one where if you don't offer coverage that meets minimum value standards, or if the coverage is not considered to be affordable based on the ACA safe harbors, you may incur a penalty. So yeah, interesting that those penalty amounts are actually going down. That doesn't happen too often. And so this kind of brings us to the end. So thank you for joining us today. I know we covered a lot of information, but sometimes I think it is helpful to just take a small look at each of these topics. Again, NFP has resources on everything that we talked about today. So if you want to take a deeper dive, definitely reach out to your consultants or account team if you are wanting some of that additional information and you don't currently have it. Otherwise, thank you all for attending today, and we hope that you learned a little something today, and definitely stay tuned to our Get Wise Wednesday presentations the rest of this year. Amber, go ahead and take us out, please.
All right. Thank you, Kelly and Sharon, for sharing your valuable time and expertise with us today. To reiterate, today's presentation was recorded. We will be sharing the recording in the follow-up email and on the NFP website. If there are any portions of this call that you missed, by Monday, you'll receive an email with a link to the full recording. The PowerPoint slides used during this presentation will be shared in the same email. At the end of this call, a survey will populate in a new window. Please take a brief moment to complete the survey, as it lets us know what topics are important to our listeners and helps make our education program as current and relevant as possible. That concludes our webinar for today. Thank you everyone for joining us, and have a great day.